started. Welcome to the University of Texas MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for October 30, 2020. It's an honor to have everyone here. Okay, here we go. Let's see. Adventures in Neuro-Oncologic Diagnostic Medicine. All right, let's start with the molecular signature warm-up. Okay, we're just going to jump right in, right? We're not going to mess around because we only have an hour. We're going to have to stop at 7. So let's jump right into molecular signature warm-up. And what I want to know is a differential diagnosis. All right, and here it is. This is the Oncomine, also known as the solid tumor genomic assay. That we use here at MD Anderson Cancer Center, and it's a visual display, so we can see patterns that way. And underlying genes are genes that the neuro-oncologist has requested. Circled genes are those that have an alteration, and we'll see what the specific alteration is in just a second. But the visual display is highly effective in telling you instantly that there's an alteration. All right, so I would like to know differential diagnosis. As you can see, there's an IDH1 alteration. Do you have a differential diagnosis? Anyone want to unmute if you have that capability and give me a differential really fast? Okay, good job.
Yeah, Dr. Fuller, I'm here, Zainab. So
yeah,
I think about astrocytoma, diffuse astrocytoma, or oligodendroglioma with non-canonical mutation other than the IDH1.
Okay, perfect. All right, that's perfect. All right.
Yeah.
All right. Let's get granular. Let's get granular with it. Here's the specific mutation. All right. That is the section on our reports, Oncomine report, just below the visual display are the details, right? And so here's the details. All right. Now I'm going to ask the same question. What is your differential diagnosis now? Has it changed? The answer to the question is yes, it just changed big time. Big time. Would you like to see it again? Okay, this is chondrosarcoma. How did you know, maybe not absolutely, but strongly suspect that this was not a glioma, that it was chondrosarcoma? How could you possibly know that? It's the granularity. It's your knowledge base. How deep or superficial is your knowledge base? The answer is right here. All right, let's, I think we need to do a brief review of diffuse astrocytoma, IDH1 and IDH2 mutation status. We talk about, as Dr. Harb mentioned, canonical versus non-canonical point mutations. Let's look at them. Okay, canonical IDH mutation accounting for 90% of all IDH1 mutations in diffuse gliomas. IDH1 R132H, that's specific point mutation, all right? H. Non-canonical IDH1 mutations accounting for about 7%. Now, if you do the math, 90 plus 7, that's 97, which means only 3% of IDH mutations in diffuse gliomas are IDH2, by definition non-canonical mutations because they're rarer. All right, that's it. Now let's have a look. Listen, let's have a look at the non-canonical IDH1 mutations. We actually know, what they are. Every single one of them. Notice that the R132C is listed first, and I've increased the font size, right, of the C, because R132C, that point mutation, is the most common of the non-canonical mutations in IDH1. Then IDH1 R32G, S, L, V. Here they are writ large. Quick question. In the test that I just gave you, oh yes, it was a test. In the test that I just gave you, it was R132F. Where is F in this list? It looks a little bit like a trip to the optometrist or ophthalmologist, doesn't it? See, C, G, S, L, V. It's like, what letter is not there? F is not there. F is not there. That was the point. See, that's what we call I for detail, and in this case, it relates to the breadth and depth of your knowledge base, and all of us need to increase our knowledge base, right? And this is lifelong learning, right? All right, here was the key. IDH1 R132F, what you should immediately focus on that F, and the first thing you think is, well, it's not H, therefore maybe it's a non-canonical, and you're thinking, now wait a minute, I did attend the Houston Area Neuropathology Review, and I actually have the book, and in the book are the list of the non-canonicals, but did you just not even pay attention to it? Have you ever go back to the paper, look at the paper? You ever have a tumor where you know the details of what non-canonical ID20 is and you look it up to see? Yes, see, that's what we're talking about. Okay, did you like that? I like that. That was a really fun warm-up. Okay, let's do something in our next warm-up. Let's do something a little bit different. By the way, I can see the chat. I've got the chat function working this morning. So if you're more comfortable just typing in chat, then I will be able to see that. I'm pretty sure. Okay, let's do something a little bit different in the warm-up. A tale of two tumors. All right, here's what I have for you. And look, as I always say in this conference, all of the cases that I'm showing you are from the last 2 weeks. And so in other words, the interval between the time I last gave the conference, these are all current cases. I'm not digging around in files. I'm not pulling stuff off the web, literature, et cetera, et cetera. These are current cases. That's what makes it so dynamic, is because it's real. It's real and it's right now. Okay, 2 patients, listen, 2 patients with solitary, circumscribed, intradural, extramedullary, non-dura-based primary tumor. All right, 2 patients. What I want to know, and I'm going to show you the imaging for the 2 patients, just a snapshot, it's all you need, and I would like to know the differential diagnosis for each patient. Now, let's quickly review the rules of differential diagnosis. The differential diagnosis is not listing all 120 primary brain tumor types alphabetical. That is not a differential diagnosis. That's moronic. Differential diagnosis is a list of the possibilities ranked in order of the most likely first, and then proceeding down to the rare, and then the zebras, and then the case report, things that no one has ever seen, right? And the differential diagnosis changes depending on the data that you have. As we get more data, as we go through the evaluation of a patient, the whole patient, not a glass slide, not a radiology image, but evaluating the whole patient, we add data, age, gender, imaging features, molecular signature, histology. We're building it. All right, I want to know the differential diagnosis for each patient. All right, here we go. Patient 1, patient 2. You can see these are both sagittal, pretty much mid-sagittal MR images. I'm showing you 2 for patient 1, which is T1 post and a T2, native T2. You can see the fats, right? And then on patient 2, it's just a T1 post. Okay, can everyone see the lesion? I think you probably can. These are lumbar cistern, 2 different lesions. Now the question is, what is your differential? Now I see a few people are just giving these are 2 different patients. Listen, these are different diagnoses. They are not the same. Now I can see people responding and they're not saying 1 or 2. They're just giving a generic. Well, come on. you have to commit. I'm seeing schwannoma, I'm seeing myxopapillary ependymoma, and you have to say which one. Okay, Andrew Gilbert. All right, patient 1, I've got schwannoma. All right, that's for Dr. Gilbert. I bet that's patient 1. I don't see 2. Okay, Kristen Huntoon, 1 myxopapillary ependymoma, 2 schwannoma. Got it? Anyone else want to play? You can't win if you don't play, and you won't learn as much, all right? Okay, Zainab Harb just said something really good. We will get to it, Dr. Harb, all right? Okay, everyone right now, look, here's what I was hoping that everyone would do. I was hoping that you would notice patient 1 is boxcar shaped. In other words, it has a blunt, particularly the inferior, the caudal margin is blunted. And that's what myxopapillaries tend to look like. And I was hoping you would notice that patient 2 is spherical, more or less, spherical. And I wanted you to go for schwannoma for the spherical one and myxopapillary ependymoma, all right? Now, the answer is 1 is a schwannoma and 2 is a myxopapillary ependymoma. All right, and again, these are cases from the past 2 weeks. Now, here is the point. The point is there's always an imaging spectrum, and sometimes they say a little bit of knowledge is dangerous, so maybe you know that the characteristic imaging presentation of myxopapillary ependymoma is boxcar. We say sausage sometimes. Sausages have rounded ends for the most part, right? Boxcar, like the railroad cars and the tractor trailers, right, are squared off, and that's highly characteristic of myxopapillary ependymoma. But as you can see in this example, schwannomas can have exactly that look. That's the point, and this is why This is why there is always a differential, and you can rank the differential in what is most likely. And if you said myxopapillary ependymoma for patient 1, then you are dead on correct. That's what should have been number 1 in your differential diagnosis. Guess what? If you think you're super smart by trying to play the game and going the opposite, I can tell you at tumor board and in the radiology report and in my brain, we were all thinking that patient 1 was going to be most likely a myxopapillary ependymoma, all right? And that's the correct answer for the differential. But there's always a differential. The differential is going to have to include schwannoma, absolutely. And then for the myxopapillary ependymoma, they're not always, see, the smallest examples, listen, the smallest examples of myxopapillaries are spherical. They don't become a boxcar, fully formed, ab ovo, all right, or was it Urbe Condita from the founding of the city? That's Rome. You know, they're not born that way. They start small, just like hemangioblastomas in the cerebellum. They don't start as a cyst with a mural nodule. They start as a tiny solid tumor, and then as they enlarge, they frequently develop a cyst, which can be larger than the tumor. Everybody got it? Okay. Now, quick question. Dr. Harb already nailed this one from the get-go. What other primary tumor entity, in addition to schwannoma and myxopapillary ependymoma, should be in the differential diagnosis for both of these two non-dura-based intradural extramedullary solitary circumscribed masses? What other tumor? Now, Dr. Gilbert says paraganglioma. Yes, you're right, Dr. Gilbert. Again, but there's something before paraganglioma, all right? And you've already said it, but not everyone heard that or saw that. The answer is meningioma. Now, look, I made a point. Listen, I made a point of saying, which is true, these tumors that we're talking about are not dura-based, no dural tail. When the surgeon, when the neurosurgeon, when Dr. Kim goes in to take the tumor out, it will be confirmed that this is not a dura-based tumor. Now, I was hoping that I would get most of you to bite on, therefore, it cannot be a meningioma, because meningiomas in the lumbar cistern are dura-based. And you know what? You are correct in many instances, maybe most. In most instances, lumbar cistern meningiomas are garden variety dura-based. Yes, except for one variant. One variant is not dura-based. They're virtually, you never say never, I'm going to say it, they're virtually never dura-based. And you have to know that in order to put the entity in the differential diagnosis, all right? Now, if you just included meningioma in your differential for a non-dura-based mass in the lumbar cistern, that's not good enough. Now, I'm sure, it's certainly possible to have a non-dura-based meningioma that's fibrous or pseudomonas, et cetera, certainly. Yeah, everything occurs, they do. But listen, there's one variant in particular whose favorite sites, if you will, are posterior fossa and spinal cord, particularly lumbar cistern, which is virtually never dura-based, all right, in the lumbar cistern. It's always arising from the arachnoid cells of the arachnoid trabeculae, which are woven in between all of the roots of the cauda equina. You knew that, right? The lumbar cistern is full of arachnoid trabeculae. Meningiomas come from meningothelial cells. It's arachnoid trabeculae. Okay, which variant? The non-dura-based variant. I'm driving it home. This is for anyone who doesn't know it, right? I know we have some advanced people like Dr. Gilbert, Dr. Harb, who knew this. Everyone in this conference, whether you're neurosurgeon, neuro-oncologist, neuropathologist, neuroradiologist, general radiologist, we need to all be able to speak the same language, have the same database, right? Which is the non-based. All right, now listen, very important. If you do not know which lumbar cistern meningioma variant is usually not dura-based, you are not yet a neuro-oncologic diagnostic medicine physician, and you must keep attending the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference. Now, if you did know which lumbar cistern meningioma variant is not dura-based, you must keep attending the conference anyway. Okay, I'm sorry, no exceptions. You still have to attend the conference, because if you knew this one, I promise you, I'll have one coming up future conference you won't know. All right, it's clear cell sclerosing. Clear cell / sclerosing. The sclerosing part comes from many clear cell meningiomas, particularly in the lumbar cistern, with age, develop this massive collagenous stroma. Tons of collagen. That's called sclerosing in the older literature. Clear cell sclerosing. Listen, here it is, bottom line. Clear cell / sclerosing meningiomas. Now, this is a grade 2. Did you remember that? The two that start, you know, with the C, chordoid and clear cell are WHO grade 2, not 1. Clear cell meningiomas are usually not dura-based in the lumbar cistern. All right, let's look at literature. Did I just make all that up? Of course not. Here we go. 2 cases of non-dura-based clear cell meningioma of the cauda equina. Pediatric non-dura-based clear cell meningioma of the cauda equina. Case report, review the literature. Okay, what is the literature, by the way? Did they review all 4 cases? Is there only 4 case reports in the literature? No, here's the table. Each line here is a different report. This is not rare. Now, you know, rare is relative, isn't it? Rare is relative. Now, I have had tremendous experience with clear cell meningiomas and in the lumbar cistern. Not all of them here at MD Anderson Cancer Center. Many coming in as consultations, you know, et cetera, et cetera. Look at that. How could you not know with that many case reports? I mean, going way back, what do we see there? I see a 2000, 2001, yada, yada, yada. 1995, look at that, third from the bottom, all right? Anti-penultimate, if you will. All right, let's look at the imaging. Look at the imaging of clear cell meningioma. Does that look like a myxopapillary ependymoma or a paraganglioma or what? Yeah, absolutely. Non-dura-based intraspinal clear cell meningioma, just more imaging from that paper. Take a look at it. All right, burn this, listen, burn this into your brain. Yes, non-dura-based lumbar cistern, put clear cell sclerosing meningioma in your differential diagnosis. Here's a nice one, Jane Resurge. Intraspinal familial clear cell meningioma in a mother and a child. Wow. Here's the imaging. Look at that. Amazing. Hey, everybody got it? Yeah. Oh, yeah. You should put myxopapillary ependymoma number 1 in your differential for this imaging. Absolutely. Don't change that. Just don't forget to include clear cell meningioma. Okay. Well, you know, we have to do molecular signature of clear cell meningioma, right? All right. Anyway, I'm going to give just a second. Anyone who wants to text me the molecular signature of clear cell. And I can only give you about 5 seconds. You know why? Is because some people, especially the young people, are so fast with the cell phone that you can look it up almost instantaneously. Okay, here we go. SMARC-E1 mutation screening, classification of clear cell meningiomas. All right, now here's the bottom line. Differential diagnosis of a non-dura-based intradural extramedullary solitary circumscribed lumbar cistern mass. Schwannoma, absolutely probably the most common. Myxopapillary ependymoma, yes, absolutely. Meningioma, now you know. And there's one other which is as rare, maybe rarer, listen, maybe rarer than clear cell meningioma, and that is paraganglioma of the phylum terminale. Okay, and that's what Dr. Gilbert had said early on, trying to game the system. Is that a fair assessment, Dr. Gilbert? Trying to game the system, knowing that I don't show you a meningioma with psammoma bodies. You're not going to see that in this conference unless there's some sort of a bizarre twist. Everybody got that? Yeah, paraganglioma of the phylum terminale. What does it look like on imaging? Typically, it looks virtually identical to myxopapillary ependymoma. Typically long sausage box cord, that type thing. The pathologist is the one who typically figures that out. Hey, now listen, hey, quick question. I think Octavio, I think you said, I don't know if you can look at our case. Can you see on both images, there's a tiny little dot. Let's see if you see what for. See right here below, inferior, all right, to it. That looks like a drop metastasis, and that is exactly what everyone was thinking at tumor board, that this was going to be myxopapillary ependymoma with a drop metastasis. Guess what? It's not. It is not. It is a schwannoma. That may have been a baby schwannoma. It was not apparent. Okay, at surgery, it's all good. Now, listen, what we've been talking about with imaging here, we're talking about spectrum, knowing the spectrum. The spectrum applies to everything, really. Imaging morphology, histologic morphology, molecular signature, spectrum. For many tumors that have, say, an alteration, EGFR, there are multiple types. Glioblastoma, for example, there are at least 4 or 5 different categories of EGFR alteration in glioblastoma. And so when you see EGFR circled in Oncomine, you have to look at the details. Is it a point mutation? Is it amplification? Is it amplification with an intragenic deletion of exons 2 through 7 with fusion of exon 1 to exon 8, aka EGFRV3. All right, and for the point mutations, of EGFR, there's a dozen. All right, you have to, the spectrum is what we're talking about. Now we're talking about imaging spectrum. Let's have a quick look. These are 10 different MD Anderson Cancer Center patients. I did not have to go to the literature and cut and paste. These are all in-house patients of confirmed histologic myxopapillary ependymoma. All right, on the far left, you're seeing two round examples, tiny ones. Incidentally identified, come to surgery, yada, yada. And then I just sort of ordered them in order of increasing size. Can you see the boxcar shape, kind of the blunted ends? All right, more rectangular than sausage or oval, if you will. This is the spectrum. Now, the thing you need to remember, listen, the thing you need to remember about the spectrum of myxopapillary ependymoma is they are not all very large boxcars. They start as spheres. Got it? Yep. Okay, spectrum of imaging morphology. It's not just the tumor per se. How about the spectrum of calcification in oligodendroglioma? Okay, these are 4 patients with CT and gradient echo on the bottom, all right, and susceptibility, the penultimate from the right, showing the spectrum of calcification. And of course, I should have put a patient in there that had no calcification, because many oligos have no calcification. Look at the top left, just one little curvilinear gyroform, if you will, and frontal lobe really elevates your suspicion of meningioma, and it's increasing. Got it? How about this? Spectrum of T2 flare mismatch. Okay, again, 8 different MD Anderson Cancer Center patients, all with tissue-confirmed IDH mutant diffuse astrocytic disease. Look at the spectrum. And I'm actually showing only classic T2 flare mismatch, which means suppression of the T2 hyperintensity in the majority of the center of the tumor. You can also have, part of the spectrum would be only a portion of the T2 hyperintensity is suppressed, and we see those as well. Complex examples, which may have cysts, and in the solid portion, a portion of it may be suppressed. Now, where do you gain this experience with spectrum? Well, the best teacher is experience. What I would recommend is you do what I have done. You spend 30 years in the field. You spend 30 years in a field, then you will become an oncologic, neuro-oncologic diagnostic medicine physician. All right, but by attending conferences like this, I am trying to impart that information and principles. Principles are always more important than factoids. Okay, did you like that? All right, let's take a little quick break and look at language watch. Okay, I love this. Everyone goes through the medical record. No one's perfect. My reports aren't perfect. Yours aren't. Okay, and the op notes, I know Dr. Kim would say yes. And we're so busy, it's very difficult. But, you know, listen. For radiologists and pathologists, what is your output? Your output is your report. Now, Dr. Kim has an advantage over us because her op note is not her output. Her output is curing patients and helping patients by removing tumors, by taking biopsies that give us a diagnosis. That is a primary output. The neuro-oncologist, chemotherapy, all right, interventional radiologist, right, obliterating vascular malformations, etc. For diagnostic physicians, our output is your report. It really needs to be accurate, precise, informative, to the greatest degree you can. Okay, here we go. Let's play a game with this one. Can you spot the error? I'm going to read it. It's point number 2. The relative paucity of the patient's symptoms, the lack of parenchymal involvement, the absence of hydrocephalus speaks against an acute infectious meningitis. Furthermore, the relative sparing of the basal cisterns mitigates against infectious inflammatory processes such as sarcoid, TB, and IgG4 related disease. Where is the error? Okay, I'm going to wait just a second for someone to chat in what the error is. What is the error here? Okay, I'm getting some really good stuff. Basal cistern can be TB, IgG4. All right, how's IgG4? No. I'm not saying you're wrong. The error is mitigates against. Are you kidding me? Mitigates is to, yes, thank you. Alosawan Ogumbona. Good job. Yes, mitigates. To mitigate is, you've heard of mitigating circumstances. They're lessening. lessening, not intensifying. It's militates, not mitigates against, militate, military forces. It says no. Everybody got that? This is one of those common, just stupid things. And listen, if you thought that mitigates against was really the phrase, this has been a good day for you, because that will not happen again, right? Militates against. Fantastic. Hey, let's do a CT warm-up. Anyone up for CT warm-up? Okay. I want a diagnosis. I'm going to wait for a chat, okay? And the diagnosis, a diagnosis does not have to be precise to the molecular signature all the way like that. It's just, what can you say confidently from the information that you know? What is the most likely explanation for what you're seeing, okay? All right, here we go. What's the diagnosis? Wait just a second. Let's see if we get someone to render a diagnosis on this. What is your diagnosis? Nice CT. Okay, yes, Kristen Huntoon, got it. I'm gonna wait just a second. Anyone else want to play? Okay, I've got Langerhans cell histiocytosis from Octavio. Sergio Pino Oviedo, yes, a longer LCH. Wow, that's awesome. Okay, let me show you an oblique. How about this? Do you like it full on? Okay, Dr. Gilbert says a bullet hole. Yeah, I like that. I need to show you the exit wound. Okay, that's good. Dr. Gilbert practices in San Antonio. Okay, now as we know, Houston, you would never see such a thing as gunshots and things like that. But okay. The bottom line is wormy and bone. Ooh, Octavio's getting greener with it. Okay, how about this? Do you like this conventional a little bit better? Okay, this is a burr hole. That's a burr hole. Burr hole for what? For stereotactic biopsy, for laser interstitial thermal therapy, for a shunt, for an Amaya reservoir. It's just a burr hole. That's what the burr hole looks like. Do you like it? Yeah, Sergio said it looks different now. Yeah. I mean, put that with this. Now look, what we're talking about here is just a slightly different perspective. Maybe you've never seen it in this perspective. This is what you're used to. All right, we need to step out of the box. You need to be able to visualize things in 3 dimensions. Now, of course, I made it more challenging because we have people of all levels of expertise in every field attending this conference: neurosurgery, neuroradiology, neuropathology. I had to make it a little more challenging by giving you basically a lateral view. All right, but it's still possible to tell it's a crater. All right, anyway, okay, let's let that. Okay, you know what? I know that I made that a little more difficult than it was, but it was so simple, burr hole. I think we have to up the game with the CT warm-up. Don't you agree? That was not quite an adequate CT warm-up, so I'm going to give you a second chance to play CT warm-up number 2. All right, this is going to tell the story. All right, everyone who's been attending this conference for any length of time, so especially those who attended the old pre-COVID Thursday morning, initially neuropathology conference, and then it was the radiology pathology correlation, which I really dislike that because it's like after the fact, the game's gone. Now it's integrative diagnostic medicine because that's upfront live. Tell the story. Here's how it works. I'm basically going to show you an image. Listen, I'm going to show you one image. Could be histology, could be molecular signature, the Oncomine visual display, could be radiology, and I want you to tell the patient's story. I don't want something stupid like glioblastoma. Glioblastoma is not a story. That's a diagnosis. A 3rd grader can give you that. I want you to analyze the information, all of the information in the scan, and create a reasonable scenario. And we used to do this all the time at the Thursday morning. How much information can you draw from a single image to be able to understand the patient? And this is a fantastic example. And okay, everybody ready? That's enough build-up. All right, I'm going to change it even a little bit more. Guess what? Usually I show you the pre-op. We always emphasize pre-op imaging, right? Because that's where all the biology is. For a diagnostic medicine physician, you don't want to see a hole. You don't want to see a temporal lobectomy, post-temporal lobectomy MRI. It's a hole. they all look the same. But I'm going to show you a post-op CT, and I want you to recreate the story. All right, let's do it. Okay, I tell you what, if you want, you can type in the chat. Just give me something intelligent. I want you to recreate the story. Do you like this? Is it something a little different? Maybe you've never seen it like that. Yeah, Sergio says that looks different. Yes. Okay. Here we go. All right. Anybody want to play? Okay, Kristen Huntoon, you are right on the money. All right. Octavio, very good. All right. Kristen is saying a meningioma, bicoronal surgery. Octavio is saying skull-base sarcoma. Okay. I like both of those diagnoses. One is better than the other. Octavio, look at the rest of the information and tell me why this is not sarcoma. Why is it not sarcoma? This is the point of the exercise. All right. Yeah, Kristen Huntoon nailed it. All right. Sahara, all right. Sahara Cath, Enter the Dragon. Enter the Dragon, Sahara Cathcart. Oncologic neuropathologist currently performing molecular pathology fellowship, nailed it. Bifrontal meningioma, multiple meningioma syndrome, NF2. Now listen, the reason why I'm saying it up front, I guarantee you Sahara's been gone for what, a year now or close to a year. There's no way that Dr. Cathcart has seen this and she nailed it. Now, okay, let's run through it. Would you like to see the pre-op CT? Okay, I want a diagnosis. I've already given it to you. This is the pre-op. I could have shown you the pre-op. I chose to show you can get the same information on the pre-op. It leads to the same conclusion. Why? Listen. Why is this not sarcoma? From the post-op, why is it not sarcoma? Here's another. Okay, I put this in. Would you like for me to just hand it to you? Just hand it to you on a platter? There. Better? Would you rather I just shown you this the first? What are you seeing? What's it called? Anyone want to chat in? What this is? Yeah, starburst. Very good. Andrea Gilbert. Starburst. What's the other name for it? Starburst sign. There's another name. Thank you, Dr. Cathcart. Hair on end sign. Now, starburst hair on end can be, it's not specific for meningioma. Osteosarcoma absolutely can show this. So the question still remains, why do we know it's not sarcoma? All right, and there's the whole thing. I mean, I'll tell you, this is hyperostotic meningioma for sure. Have you ever seen it like this, by the way? If you haven't seen hyperostotic meningioma from this perspective, 3D reconstruction of CT, that's why you come attend the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference so that you can see things like this. Yes, bone remodeling. All right, MRI. There's the MRI. What do you think about that? Okay. What is the sign? What is the sign we're seeing here? What is the sign? It's a classic sign. It's not the starburst. We've already, okay, dural tail. Yeah, dural tail is good. Okay, very, very good. All right, Andrea Gilbert said it first. Mushroom. Sergio Pinovieto. Yes, Sergio. Mushrooming sign. What does the mushroom sign mean? It means grade 2 or grade 3 meningioma because there are differential centers of cell proliferation, clones, which are some are dividing rapidly, some not so much, and it leads to a lumpy, bumpy contour, not a beautiful, smooth interface like a grade 1 meningioma with the underlying brain. See all the bumps? Yeah, absolutely. This is histologically confirmed to be actually anaplastic meningioma. So the mushrooming sign means grade 2 or grade 3 meningioma. I mean, that's most common, other things. All right, here is the story I was looking for. I think Dr. Cathcart nailed it first. Multiple meningiomas, including hyperostotic. Now, this is after I showed you the MRI, including hyperostotic and anaplastic variants rising in a setting of NF2. Now, Dr. Cathcart got all of that except for the atypical anaplastic because I had not shown you the MRI yet from the first image. All right, now listen, here's the meat. Here is the meat. This has been an interesting case. It's dramatic, but there's a principle which is more important than dramatic images. What feature held the key to understanding the entire clinical scenario, not just a diagnosis like meningioma or sarcoma, understanding the entire scenario, not just one elementary second grader tumor diagnosis. Upon examining the first CT image, you could get it from the first CT. What is it? All right, if you said this was the key feature, you've missed the point of the exercise. The point of the exercise, it's like the lady in the red dress, Matrix. Yeah, right. There's a point to the exercise. That's not it. There's the key feature. The key feature is multiple craniotomies. So what does that tell you? Do you think this patient had multiple sarcomas, skull sarcoma? No, highly unlikely. We're putting it together. That's at least 1, 2, 3, 4 craniotomies. And the other, some of these are healed. All right, this is over time. All right, same thing. Have a look here. If you said this was the key feature, again, you've missed the point. Here is the key feature. Multiple craniotomies, many of which are healed, which means remote, right? So you were talking about a lower grade thing, and what patient can have multiple craniotomies, supratentorial and infratentorial, and a hyperostotic meningioma, NF2. And that was it. Did you like that exercise? Okay, yes, very good. You know what? I think we are ready to move on to patient number 1, 37-year-old man. All right, everybody feel warmed up? Are we warmed up enough? Yeah. Okay, we spent, what is it, 36 minutes warming up. Let's try a real patient. Okay, I'm looking for a differential diagnosis. These are serial, axial images, serial cuts, T1 with contrast. Diagnosis. All right, Kristen Huntoon says breast, leptomeningeal disease. Okay, interesting going straight to breast. Breast does do this, absolutely. All right, I've got from Octavio, meningitis, sarcoid, lymphoma. All of those are good. Subarachnoid. Okay, the point is, you know, Andrea Gilbert, Pachy meningitis. The problem with, listen, Dr. Gilbert, the problem with Pachy is the dura. Pachy meningitis is meningitis confined to the dura. Do you see how the process is going into the sulci? And the dura doesn't go in the sulci, right? It bridges. The arachnoid goes to subarachnoid space, okay? Is that cool? Although I like that. All right? Here we go. Let's just look at one, big. Oh, yeah, okay. Here's the point. Every single sulcus, almost 98%, is full of contrast-enhancing material. And in this world, in my world, which is the cancer hospital, that's going to be leptomeningeal disease until proven otherwise. All right, here's a biopsy. Here's the biopsy. This is it. Open biopsy, which was good. So we got a nice representative sample. And I'm going to tell you, because it's not obvious at this power, all of that stuff is in the subarachnoid. So that is a big dilated subarachnoid space, okay? Full of purple stuff. Let's go to high power. All right? There it is, subarachnoid space. Differential diagnosis, well, it's a tumor. Breast, yeah, absolutely. What else? Besides breast, what else could this be that loves to go to the leptomeninges? Lung, sure. And lung is that's Kristen Huntoon. Yes, lung, very common. What else? Yes, Leo Ballister. Okay, Enter the Dragon number 2, Dr. Ballister. Oncologic neuropathologist, UT Houston. Melanoma. Yeah, this is melanoma. This is melanoma. Okay, question. What is the diagnosis on the path report? Anybody want to make a guess? What is the diagnosis on the path report? What does it say? What does the diagnostic line say? I can tell you that we had at least one person get it totally wrong. I'm talking about clinically. Do you know what they said? You know what they said this was? Metastatic melanoma. On what basis? On what basis would you call this metastatic melanoma? Now, if you want to create a differential, I'm with you. Because if I don't give you any other information, metastatic melanoma has to be number 1 on your list. But then after that would be primary melanoma. I mean, that happens, right? Okay, here's what I can tell you. Here's what I can tell you. CT, chest, abdomen, pelvis, no melanoma. Skin examination, no melanoma. Endoscopy, no melanoma. Does that mean there's no melanoma systemically? No. It still could be cryptic. It could be tiny. It could be regressed. no history of moles, et cetera, et cetera, et cetera. Okay, here's another one. Here's another piece of the puzzle. I just showed you axial cuts, right? I didn't show you everything. There is, listen, there is no parenchymal disease. Nothing in the brain, per se, parenchymal. It's all 100% leptomeningeal disease. Well, leptomeningeal and what? What just showed up? New feature. See, we're building that 8-Venn diagram, right, model of convergent evidence leading us to the correct diagnosis. What just showed up new? You could see it on the low power, but now it's obvious. What's the new feature here? All right, yes, Dr. Gilbert, infiltration of the Virchow-Robin perivascular space. Here's another one. That is a blood vessel in the center. So from the subarachnoid space, the melanoma is crawling along the perivascular Virchow-Robin spaces into the brain. Melanoma loves to do that. There's higher power. Here's a third one, okay? These are all melanoma in perivascular Virchow-Robin spaces. The arrows are showing you on low power. Now, I tell you, if you were really a hot shot, and I didn't ask, but if you were a hot shot, you may have identified these little guys from the initial, right? They just caught your eye, and you couldn't tell. You couldn't tell with this magnification what it was, but you might guess if you have a knowledge. Once I told you this is all subarachnoid space, you might guess, I wonder if that's actually going to be the tumor or the process invading the Virchow-Robin spaces. See, you need to get the suspicion, soupçon, if you will, at low power, all right, and then you investigate at high power. All right, what do you think the diagnosis is? It's not metastatic melanoma. It is a diagnosis of exclusion for sure, but this is not metastatic melanoma. What is it? Okay, Sergio, meningeal melanomatosis. Yes, that is correct, but let's give it a slightly different name. Primary diffuse meningeal melanomatosis, a rare form of meningeal melanoma, case report. Primary diffuse leptomeningeal melanomatosis, description and recommendations. Primary diffuse leptomeningeal melanomatosis. I'm reiterating, I'm reiterating so that everyone takes this home, right? So you own it. All right, this paper, here's the illustration, identical to our case. Now, as I've often said in this conference, I got to be honest with you, I think our example is better, as they usually are, than what's in the literature, but that's just one of the advantages of being a tertiary care center where we see everything. Oh my gosh, that's it. Oh man, what is this? Oh man, 43 minutes. It's the shortest conference I've ever given. There's two reasons for that. Number one, I was concerned about running up against the 7 a.m. deadline. As you know, when I did this conference from work at home, I've been running about an hour 15 to an hour 20, 25 minutes, taking my time, but I truncated this one because I did not want to run over. Now, the next conference, I don't know. Right now, it's set up for 2 weeks from today, not next to 2 weeks from today, at 6 a.m. this time slot. I'm not sure if I'm going to keep this. It turns out it is incredibly difficult to put this conference together during the work week, and I think this is the 3rd week that I have been on service, and everyone I think knows that story with the volume that we have here, the conferences, the yada, 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 yada. It's incredibly difficult, and I want to do it justice. I will not present a second-rate conference. So it'll be 2 weeks from today, or we will send a message out with a new time. Okay, so it's like, watch this spot. Okay, again, thanks to everyone for attending this early on a Friday. What a perfect way to start your weekend. Thank you so much for attending. Much appreciated. And I will see you week after next at some time slot. And with that, I'll say goodbye. Have a great weekend.